Hi, I'm Andrea Watkinson, Executive Director of Cancer Services for Unity Point Health, St. Luke's Hospital, and the Nassif Community Cancer Center in Cedar Rapids, Iowa. As a leader in cancer screening and treatment in Iowa, we're proud to sponsor the Iowa Ideas In-Depth Week Cancer in Iowa series. As Iowa continues to see some of the highest cancer rates in the nation, it's more critical than ever to address the issues causing this trend and to educate our communities on the resources available in our state. This series will take an in-depth look at everything from cancer rates and causation to research and long-term impact cancer has on the state of Iowa. We'll also discuss advancements in treatment and how crucial it is to complete your cancer screenings regularly and on time. We hope you find these sessions informative and find valuable takeaways. Our overall goal at Unity Point Health, St. Luke's, and the Nassif Community Cancer Center is to reduce cancer rates and work towards a healthier state for all Iowans. Enjoy the event.
Well, hello and welcome to Iowa Ideas In-Depth Week. This is the Gazette's 9th year of Iowa Ideas. It's an initiative that explores topics that are important to Iowans. And this week we're focusing on cancer in Iowa. I'm your moderator, Sara Konrad Baranowski, managing editor here at the Gazette. I'd like to recognize Iowa Ideas presenting sponsor, ITC Midwest, and our In-Depth Week sponsor, Unity Point Health Cedar Rapids. Thanks to them for making this session and Iowa Ideas possible. During our time together today, we'll talk with our panelists and address audience questions. If you have a question at any point during the session, you can type it into the Q&A box or in the Zoom chat, and our tech host will forward it to me, and we will try to include it in the conversation if we have enough time. Today, we'll be discussing pediatric cancer, what cancers affect children, research into the disease, and treatment. I'm joined by 3 panelists. I'll ask each of them to introduce themselves and share their connection to pediatric cancer. Dr. Nick Fustino, we'll start with you, then Dr. David Dickens, and then Natalie Steuer.
Morning, Sara. Thank you very much for having us. My name is Nick Fustino, and I'm the medical director of the Blank Children's Cancer and Blood Disorder Center here in Des Moines. And I have been a pediatric oncologist for 14 years.
Thank you for having us, Sara. My name is David Dickens. I am the clinical director of the Pediatric Cancer Services at University of Iowa Stead Family Children's Hospital, and I've been a pediatric oncologist for 23 years now.
Hi, thanks everybody for being here. Thanks, Sara, for presenting this for us. My name is Natalie Steuer, and I'm a mother to a child who was diagnosed with cancer in 2021.
All right, well, thanks. We'll just jump right into questions now so we have enough time to complete our discussion. Dr. Fustino, we'll start with you. Could you set the stage for us and explain the state of pediatric cancer care in Iowa? What kinds of cancers are children being diagnosed with? How rare is pediatric cancer? And how does treatment of children compare to adults?
Sure, happy to. So pediatric cancer affects about 15,000 children per year in the United States. So that's new patients with cancer. But when you think about it, compared to adults, 2 million adults are diagnosed with cancer every year. So it's relatively rare. However, it is the #1 cause of disease-related death in kids. So it's certainly a huge medical challenge currently. As far as Iowa goes, we see about 140 new patients a year in the state treated at 2 different hospitals, the University of Iowa and Blank Children's. Certain cancers that we see in children, #1 would be acute lymphoblastic leukemia. That's the most common cancer in kids and affects about 30% of those 15,000 children. And if you think about it, cancers in kids are very different than the ones we see in adults. In adults, you think of breast cancer, prostate cancer, colon cancer, and those in children are exceedingly rare. So leukemia, far and away the #1 type of cancer that we see. That's followed by brain tumors and then other solid tumors. And then in teenagers, Hodgkin's disease is very common, as are certain testicular and ovarian tumors. So the types of cancer we see in kids are extremely different. And our approach is fairly unique as well compared to adult cancers. So We are part of a group, and so is the University of Iowa, called Children's Oncology Group, and that's a group of over 200 hospitals in North America and even outside of North America that all collaborate to improve cure rates with kids with cancer and reduce toxicity. And that's an important point there, because when you're treating an adult with cancer, a 70-year-old, say, you're not really worried about, a side effect that could happen in 20 years. Whereas in a child, our goal is not just to give a few more months of survival. We're shooting for 70 years when you have a 4-year-old, with leukemia. So our approach and goals are different at the outset. David, I don't know if you could elaborate on that a little bit more.
Oh, that was well said, Dr. Fustino. I think that when I think of the idea that we have a whole specialty dedicated to children with cancer, is to acknowledge that sometimes the diseases are different, but the dynamics are different and the host is different, meaning the patient. So some of the ways we use drugs and deliver drugs has to be different in pediatrics. So it's not a big field, but there is a need for us to have a dedicated effort on the problems in pediatric cancer.
All right, Natalie, I want to bring you into the conversation. Would you share your family's story? You said your son, or you're a parent of a child with who had cancer, but what cancer did he have, and what did treatment look like for your family?
Yeah. So my son was diagnosed in 2021 at the age of 3 with rhabdomyosarcoma. So as Dr. Fustino talked about, one of the most common childhood cancers they see is usually acute lymphoblastic leukemia. And my son had a little bit more of a rare type, which falls into the solid tumor category. It was a tumor that was in his leg that metastasized throughout his body. And the treatment was very hard. He treated at University of Iowa, and he would get treatment weekly. And then he would also have once a month, he'd stay overnight for treatment. But adding to it is he had radiation along with his treatment plan, which was really hard. It was 30 days of radiation. So we drove back and forth every day. We are located in Dubuque. So it was a long haul. It was 66 weeks in total. And that was including maintenance chemotherapy. So when he was done with his frontline chemotherapy, he went into maintenance therapy, meaning he didn't go as often. And he also was able to do some chemotherapy at home.
And how's he doing now?
He's doing well. He is 2 years off of treatment, which is wonderful. He has his 2 years scans coming up in July. So he's doing well, but overall he's doing well. But also, again, like Dr. Fustino said about toxicity, quality of life is definitely a challenge.
Well, and I wondered if you could talk a little bit about that, because I think for a lot of people, myself included, pediatric cancer isn't something that we are personally acquainted with. We maybe know someone who's had a diagnosis, but we don't understand exactly what kind of toll that takes on a family. Like, I'm thinking of you driving back and forth between Dubuque and Iowa City that much, and, being able to maintain work. And I don't know if you have other children, but, tending to the family, but also, like you referenced, the toxicity and the effect that the treatment had on your son. I wonder if you could talk a little bit about that.
Sure. At the time we had, he wasn't a baby, but his little brother was like 6 months when Sage was diagnosed. So it was hard. It took the driving was really hard. My body would, like my right arm would, like, even I still have issues with my neck just from driving so much. Not on top of just like the trauma and the stress, obviously it all just kind of gets up in your body. But to talk about the toxicity right now, the radiation was really hard, and he had it in his leg. So his right leg is shorter right now. So we're dealing with just body issues as far as if any person, you stand normal and everything should be aligned, right? And like Sage's hips are like this. So we're trying to figure out, how we can make it better for him without also having a million surgeries on top of it and a million more medications on top of it. So it's been a challenge for sure.
Dr. Fustino, I wonder if you could talk about that from a physician's point of view. The toll this kind of treatment and care can take on children and also their loved ones.
Yeah, Natalie brings up a lot of great points. And one thing we really care about is the effect on families. This is yet another kind of big difference between pediatrics and adults. So for our patients, 3 out of every 4 will have to have a parent quit work or cut back significantly. I mean, if you think about the most common cancer, acute leukemia, I mean, we're looking at 70 plus doctor visits plus hospitalizations over a 2.5-year period. I mean, that's daunting. Not only that, what happens is if parents cut back on work, they may lose insurance coverage, and there's significant financial hardship on quite a few families. And then you have the family dynamic, right? You've got siblings who may fall by the wayside. Marital stress. We see a high rate of divorce in our parents. The stress that this puts on families is very, very hard. The disease itself is hard enough. And then you add all these other, social factors that are fairly unique to pediatrics in a lot of ways.
Dr. Dickens, I want to direct this next question to you. Hearing about the toll this takes on families, I imagine it also is really difficult for medical providers. And I'd be curious if you could share with us why you decided to go into pediatric oncology and why you've stayed in it for, I think you said 23 years, right?
That's after I finished my 14 years of training, yes. It's a long road, and it's interesting when I talk to any medical professional. So it's not just doctors, nurses, social workers, pharmacists, research associates, whoever states an interest in going into the field has the same response to the question, why do you want to do that to yourself? And it's very hard for people to articulate it because I think it's a calling, it's a passion. It's the type of people and human beings that you want around you when there's a crisis. Natalie probably spent a lot of nights unplanned, in addition to the chemotherapy, coming in the middle of the night with a fever, and you encounter a nurse, and that's their shift, and they're just there to do work. And the people we have delivering that care just have this tremendous humanity about them. And so what keeps people in the field, what keeps me in the field, is a recognition that despite witnessing trauma, this sort of natural disaster that hits people, brings out the best in humanity. Typically, when a child is diagnosed with cancer in their community and their family, there's a rally, and people get behind the family, and you see the best of what people are capable of. And I see that on a routine basis. And my entire career, it's felt very uplifting to know that when a fellow human being is in trouble, that there's a whole community of people who are willing to support them.
I don't know if you want to talk about this. I'm throwing this at you, but I don't know if you want to talk about the musical instruments behind you or how you relate to the kids that you treat.
Yeah. So that is true. This is my office, and I think one great thing about being a pediatrician is you get to play a little bit. When I started medical school, I didn't want to do pediatrics. That's the one thing I didn't want to do. But that was only because I had a bad example. I'm the first physician in my family, my pediatrician, let's just say he did not have good bedside manner. And then I'm actually, in addition to being a musician, a magician. So I'm a physician, musician, magician. And so I volunteered for the child life department. I would just do magic tricks at the bedside. And I got to meet some of the oncology families. And for the people who go into medicine because they want to save lives and do something significant, I immediately bonded to pediatric oncology. And still to this day, when somebody's stuck in the hospital and they're bored and I found out they like music, I'll just stop by and we'll just start jamming. So it's just a tool, and different healthcare providers have different tools that they develop to help develop a relationship with one of their patients or their families, and it's different for everybody. But I think the common goal that every doc, nurse, social worker has is whatever unique qualities that you have as a human being that you can bring into that dynamic. So it's more than just the medicine, and they get to see you as a regular person. It definitely helps in some situations when you're trying to reach somebody and communicate with them, and then you spend just a little bit of time doing something completely different.
Dr. Fustino, I want to ask you the same question, how you found your way to pediatric oncology and what's kept you working in that field.
Well, like Dr. Dickens, I'm the first physician in my immediate family. And, when I was going through my training and thinking about, what I wanted to do, I kind of always envisioned doctors having really important, life and death conversations, treating acute illness, forging, very strong bonds with patients and families over time. Also envisioned myself doing procedures and looking under the microscope and really just, embracing the science of it all. And for me, pediatric oncology had all of these things. And when I was going through my training, I was going out with a nurse at the time, and she's like, you talk differently about, this area of medicine compared to everything else. And that's kind of what sealed it for me, to, go through the 14 years of training, like, Dr. Dickens mentioned, but I wouldn't do anything different. And, as he mentions, this is a very close-knit group of professionals, and we all kind of have a similar angle going into this, really unique specialty.
Natalie, my next question is for you. One side effect of your son's cancer diagnosis that we haven't talked about yet was that maybe this isn't the right word, but kind of propelled you to become an advocate. And I wondered if you could talk a little bit about that road, how you became an advocate, and then what that looks like. What are you advocating for, and how are you doing that?
Sure. Yeah, so it actually came pretty organically. I have advocated in the past for other health-related issues, so it wasn't new to me. And as a mother, you just would do anything for your child. I mean, it's just something that comes natural to you. So you just, and not only that, but when you're in that situation and you have the personality of like an empath and an advocate, you're doing it for other people too. Just kind of like Dr. Dickens said, it's a passion, it's a calling, and it's something that really just kind of lands in your lap. And that's kind of how it started, I guess. I saw an email from the Alliance of Childhood Cancer saying we are going to have our lobby day, and I said that I wanted to go. So I asked my sister if she wanted to come with, and she did. And we found out that we were going to be advocating for the STAR Reauthorization Act, which is a bill, and I know Dr. Dickens can talk better to it, but it's a bill that gives us the federal money for grants from the NIH and the NCI. So it's that, and then accessing the Medicaid, accelerating access to kids. It's always it's a big mouth to say, and that's a really important one, which helps children who are on Medicaid go from state lines to other providers, and it's just an easier process for them to get there. So yeah, it really kind of came naturally and organically.
I want to get back to the things you're advocating for, but first, how has that, you went to the first lobbying day, but then you've stuck with it. So is it because you're seeing results from it? Is it because you believe it's that important? Why keep advocating?
Yeah, so because it's very important. It's very, very important. And I get a positive response. It's cool to see other people get inspired by my work, and to start to use their voice as well, something that they didn't think that they could do. But when they see someone else do it, that's just in the same level as they are, that they know that they can go ahead and get out there too. But there's a lot of moving parts to answer that specific question, especially in legislative issues, because the process is reactive, right? So therefore, legislation is decided by those who show up and use their voice. So we have to keep showing up to get that reactive response from legislation to keep moving forward and to keep having them reissue our bills that we're asking for.
Sara, can I add something on that? Because I watched Natalie's birth as an advocate, and we were sitting together in some offices on that first day. And many people who are trying to address barriers to progress, which is what this is all about, and like, how do we make the situation better? And we team up with legal people and lobbyists who understand how the government works. And then you pair up somebody like me who can review and answer any questions about statistics and the global picture. But at the end of the day, the power of the message is coming from Natalie. And I watched this happen, and it was done very expertly. It was personal. And it let people know that this is actually affecting their constituents in a real and personal way. And people can tune Nick and I out when we talk about statistics. But when a mom is talking about how her kid is affected by cancer, it is extremely powerful.
I wonder, Dr. Dickens, Natalie said you might be able to talk a little bit more and explain the STAR reauthorization and then the accelerating access to Medicaid.
Yep. So I was part of the Alliance for Childhood Cancer since 2014, I think. So for about 11 years through the American Academy of Pediatrics. And at the point that we started writing that bill, a lot of different groups were going to the government saying they needed something. They needed plan A, plan B, plan C, plan D. And so the legislative people said, all you groups get together and you work on a single project that we can just put through one time. And so that's what the Alliance for Childhood Cancer is. And it's there's multiple groups, national presence groups, professional groups, and foundations who literally sat in FEMA headquarters in DC in 2014 and said, let's write this out. So we did that in about a year. It was submitted to Congress in 2016, I think, or 15. It didn't go through the first year, and it went through the second year. It was signed into law in 2017, and has been continually appropriated since then. So you can have a law, and if it's not in the budget, it doesn't matter. So what this law is the STAR is an acronym. It stands for Survivorship, Treatment, Access, and Research. It's about $30 million a year that has spawned numerous research projects and granting mechanisms, which today has become critical as we are facing cuts at a federal level to funding research. Progress comes from research. If we don't have research, we are stuck. And the next Sage Steuer is going to come in, and we're going to do the same thing we did to Sage. We're going to put chemotherapy into their system. We're going to give them radiation therapy, and then there's going to be another kid out there with these things. If we want to get better, we have to fund it. So in part, the STAR Act isolates us from the NIH budget discussions, but $30 million for the whole country and all of the problems is just not that much. It doesn't get you very far.
Is that funding at risk right now, or is it
every time? Yes, every that's part of the reason why Natalie goes back and many other people is because as people are having the budget discussion, and it seems like it's happening once or twice a year now, where they're having this budget debate and government shutdown debates. The STAR Act is a part of the government budget. So people can advocate for that separately while they're debating about the NIH funding, which is a whole big issue in itself. So when I go through the American Academy of Pediatrics, it's to advocate for both pieces.
Okay. Natalie, I don't know if you wanted to add anything onto that. I was going to move on to research, which seems like a good segue, but okay. So like I said, I want to turn our attention to the research that's happening around pediatric oncology. And I think there's been a couple of references to collaboration across the state and beyond the state, and even beyond the country. But Dr. Dickens, could you talk a little bit more about some of that research and the collaboration and what's happening?
Sure. Happy to. when I started practicing pediatric oncology, we had three main ways to treat cancer: chemotherapy, radiation, and surgery. That was it. As the 21st century came about, we have developed new drugs and strategies to do better, more targeted therapy or personalized therapy. That's where we're taking drugs and designing it specifically to kill cancer, not just kill everything that's growing. We have learned ways to manipulate the immune system so we can get the immune system to attack the cancer, which is a lot easier in general for people to tolerate. So when I was a kid, the chance of me being cured of cancer was no higher than 50%. Now, if you average them all, it's about 85%. And for rare diseases, the only way to get from point A to point B is clinical trial research. And when there's only 15,000 kids a year in the US diagnosed with cancer per year, you can't do research alone. We collaborate on projects with all of the centers: MD Anderson, St. Jude's, Mayo Clinic, Boston Children's, all the big hospitals. For most of our protocols, they're all together so that we can take a new drug and a new idea and learn from it the fastest. So a lot of progress has been made over time, and we've been completely dependent on collaborative NCI-sponsored research. Most of the funding for that comes from the federal government, which is why pediatric cancer doctors are also advocating to be protective of the NIH and NCI budget, because I think we will see a screeching halt to progress in cancer care if we don't have money coming in.
Yeah, I mean, when we look at pediatric cancer, I really consider this to be, the model for disease cure, and how, other disciplines could really learn from what we do with the collaboration. It's a rare entity, and we've got 200 hospitals all working in concert to conduct, these trials to help kids. And if you think about it, 85-ish% of kids are cured for life now, compared to, what Dr. Dickens said, 50% when we were young, and, and it used to be a death sentence. And, we're still even using some of the same drugs, for 75 years. The first pediatric cancer drug, was developed in the late 1940s, early 50s, and we're still using it, methotrexate, to this day. So that certainly underscores, the need for better and less toxic therapies, which we're getting there. With leukemia, acute leukemia, like I mentioned, 95-ish% of kids are cured for life. But again, toxicity levels are unacceptable at this point, and we're really entering a great new era of science, which potentially is in peril with what's going on at the federal level. We've made such astounding progress over the last 50 to 75 years, and is it really in risk of stagnation with what's going on?
Is that collaboration, when you said that it's unique, is it unique for specific to pediatric cancer or of all cancer research?
Well, certainly there are clinical trials in the adult world, but with kids, what I love is that every child has access to the best known standard of care, most current therapies available, because again, we all work together. So a child and their family are usually able to go to the closest hospital near to them to get the latest and best treatment that's out there. And so, and I would, our field is unique, like we've mentioned, and everybody is pretty much always willing to help. So if Dr. Dickens has more expertise in a particular rare tumor, I would call or email him, and usually we can chat. It's a very close-knit community, like I said, and everybody's always willing to help each other out. And it really all comes down to doing what's best for the patients.
So I would just add, Sara, that unique is maybe the wrong word. It's the fact that we so routinely engage in new clinical trial enrollments. Even when we compare our experience with adults with cancer, the percentage of patients who are entering into these trials that have a new treatment available is much higher. than it is in adults. But other specialties kind of do it. It's just kind of caked into our specialty in a much different way at a much higher percentage. The collaboration too, I think it's worth highlighting something that Dr. Fustino said. Iowa is a smallish state by population. And we just have these 2 sites. And I think collaborating across these sites allow us to ensure that if it is possible to reduce the burden of cancer, whether it be like Natalie's situation and driving for so long, but she's just you're on the other side of us. But if you were in the Des Moines area, we would be figuring out a way to find treatment for the patient that minimizes the burden on a family. And that's where that communication throughout the state helps. And it's quite unique in pediatrics, where if you're an adult with cancer and you're getting treated at medical center A or B or C, they may not be as connected. And the entire state is just the 2 of us. And all of the docs on his team and my team are connected so that we're always looking for a way to help the family out best, whether it's in Des Moines or in Iowa City.
Dr. Fustino, you referred to the best standard of care. In these clinical trials, like no one's getting a placebo. They're getting some kind of treatment, and I kind of want to get into the treatment conversation, but I just wanted to. I think we had a conversation in our planning meeting. We talked about that no one is getting like anything less than the best standard of care.
That's essentially true. So usually, kind of general how studies would be run would be, one group gets the best known standard of care, and then the other group would receive a new medicine to see if that improves cure rates, and these things are monitored in real time. And Dr. Dickens could elaborate on some recent breakthroughs, but sometimes we come to a conclusion very early, and this benefits everyone. And patients who are on the standard arm may move to the treatment arm. Other studies actually, would look to reduce toxicity, for instance. So we identify a group based on a number of prognostic factors who may respond more favorably, and we're able to actually take away some of the chemo or radiation that we, would be giving to reduce some of those long-term effects in children. So that's kind of the general, structure. And I know Dr. Dickens is more involved at the COG level, but that's generally how we would approach it.
Yeah, agreed, Sara, that as opposed to some trials where you might be receiving a placebo, it depends on the disease. It's rather unethical to withhold known therapy to a child with cancer. So, and this is an important point because I think clinical trials are often misunderstood. People feel like they're part of an experiment. So we take our time to walk people through the individual nature of each clinical trial. I like how Nick said it, is that when you come in and you have a clinical trial available to you, I let people know that that's a choice. They have the option to participate or not. And if they don't, I would be prescribing the best known treatment for this disease. The clinical trials usually offer the opportunity to receive either that or that plus something new, something that people are excited about. So it's usually added into the standard of care. And we don't know at the beginning of those trials, is it more toxic? Is it going to help like we think it is, or isn't it? So in order to understand that, you have to randomize patients. So it's not us that's doing it. It's the central computer system that will take a patient who's newly diagnosed with whatever type of cancer and randomize them to receive either the standard of care or the standard of care plus something new. And along the way, we have the ability to change at any point. If we as the medical team or the parents feel like whatever we're doing is not in the best interest of the child, we can always just stop and switch gears to and accommodate whatever we think we need to do to make sure that the best interest of the child is the primary focus during those trials.
Natalie, I don't know if your son was a part of a clinical trial or if you could talk about that from the patient's or the family's perspective at all.
Yeah, definitely. I am pretty well versed on clinical trials, and my son was involved in a clinical trial. And I echo both of these doctors. I mean, there's not much I can add into that. They said it very well. But I liked how Dr. Dickens said it's not like some scientific experiment with like a clinical trial. That is correct. Like, you are involved in the conversations and the process the whole way as a parent, which is really helpful. And to go back to like what Dr. Fustino was talking about with COG, all of that information is available to us. So I had my son's protocol printed out. I think I don't, 60, 70 some pages, front to back. And so I knew every step of the way what he was supposed to have and what he was supposed to get. And I liked having that information to know that, I am also in this decision making with these doctors. So when you are going on a clinical trial, you are signing up to be randomized. So that is something that can kind of be scary, knowing if my child doesn't get on the arm that I want him to get on. But then again, your oncologist should be open to have that conversation with you as well. Because I did sage my son's protocol, about 3 months in, because it just wasn't working. And his doctor I shouldn't say it wasn't working for him in a certain different aspect, but his doctor was so perfectly okay with it. And we had such a genuine and good conversation, and he had no problem switching it over. So, and also letting parents know that if a trial is like, all of these drugs are available to you, and you just need to have these conversations with your oncologist, because I'm sure they are more than welcome to have it and have the conversation and to be open to your ideas as well. So it's very important to know that as a parent.
From a parent or a patient perspective, is this something that's brought up by the medical team? Do parents ask, hey, are there any clinical trials happening, or what is the usual, or what's the preferred method for determining that?
Yeah, that's a great question. So I think in the moment, a lot of parents aren't educated. I wasn't. In that moment when they tell you your child has cancer, you don't know, I mean, you hear things, you see things, right? So I'm pretty sure a lot of people are familiar with the word clinical trial. So I know that we asked just because we are familiar with the word. However, going back to what both of these doctors said, almost every children's hospital in the United States is a part of the Children's Oncology Group. So you are going to get the best standard of care no matter where you go. And if there is a clinical trial open, they will have that conversation with you. But it's a great question, because a lot of times in the moment you don't know what to ask. You're just hoping and praying that this doctor has the best treatment for your child. And 100% of the time they should.
Well, you mentioned in the moment. And this is an incredible art, I feel like. And I mean, imagine being a parent, right? This is maybe the most stressful, impactful thing they've ever experienced in their life. And you have to present a 100-page document about a clinical trial. And sometimes things are emergent too, right? Like kids with acute leukemia, we move very quickly. So you've got one half of your brain racing, and on the other half, you're trying to slow down. And then to be able to communicate this to people who come from all different backgrounds. Some do have a scientific background and are well-versed in clinical trials, or have an engineering background or in the sciences. And then you have other, individuals who have never even heard of cancer before in their life. And that's happened. And so you have to be able to, and you offer this to everybody, regardless of language, race, and, background, and make this available to everybody. So no matter who you are, you can still get the standard of care. But this is a very nuanced process, absolutely, and fully transparent. We always say, there's no secrets. I am being fully transparent with you. I am being honest. I will tell it to you straight. And that's kind of our approach, at least.
All right. This is all very fascinating. And actually, I do have another question. This is kind of just me being curious. How do you learn everything? Natalie, I don't want to toss every question to you, but how do you become an expert in your child's care when you don't have this background? Or if you, maybe it sounds like you were at least familiar with clinical trials, but
no,
it's a lot to take in.
It's a lot. No, I wasn't familiar. So like I said, Sage was diagnosed in 2021. So I've just deep dived into it. I mean, not everybody is like me. Most people are not like me. It's just something that I did. And it's just, there's a lot of resources out there. COG has a ton of stuff on their website. St. Baldrick's has a ton of stuff. There's trainings you can do, webinars like this. I'm constantly watching webinars through my son. Like I said, he had sarcoma cancer. So I'm constantly on sarcoma webinars, listening to doctors. And as I mentioned, that both doctors mentioned before, it is such a small kind of community, even though it's a big community, if that makes sense, that we all know somebody of some sort that we can connect with, and they can connect us with this and that. So it really kind of is like just a puzzle that you're putting together. But for me personally, it was just something that I just got very interested in and wanted to keep learning. And so that I knew if something were to happen to my child, I knew what to do. I didn't want to be in that situation again where somebody's looking at me and telling me something extremely foreign that I have no idea what to do or how to do anything for it. I never want to be in that situation ever again.
So thank you. I appreciate that. And actually my next question is for you, so I'm sorry.
That's all right.
Just have to talk a lot. But I wanted to get into, you said you live in Dubuque, you drove to Iowa City. And this is an issue, not just for pediatric oncology, but lots of special care that, Iowans in rural areas can't necessarily access that care where they live. And so it means driving or traveling or getting there somehow. And I wondered if you can talk, Natalie. You talked about the pain that's still in your shoulder from having to drive so much, but I think you've done some advocacy work about care, being able to access care where you live. And I wondered if you could talk a little bit about that.
Yeah. So Dubuque, and not just Dubuque, and there is a huge barrier for patients and families who live in rural areas. There is nothing remotely close. And when a child has cancer and they get a fever, because they have a port inside their body, which is a foreign object, they need to get to an emergency department within an hour of that fever starting. A lot of times sometimes that isn't the case. They can't get there that quick. So if they have an ER, most of the time they have some sort of medical place that they can get to, right? But those doctors aren't versed and educated in pediatric oncology care, especially accessing a pediatric port. So there was a lot of times that we were at the ER because my son was neutropenic, and they didn't have the port size needle. They're little, right? These little babies, they're little, so they require a certain port size. And I remember being like, this is your job. Like, what do you mean you don't have this? But we've just been so spoiled to have the University of Iowa so close and have these doctors who deal with pediatric oncology all the time. So when we go to the ER, they're dealing with adults and children. So I decided to take a picture of our port access tray and send it to whoever was in charge in that ER department and say, you need to order these. There's multiple children in this town that have cancer and have fevers and come in, and you guys don't have the right port access equipment. That's not okay. And I think that every rural community needs to have these port access tray. They need to have some sort of education of some sort to be able to access a child's port and to be able to administer those antibiotics quickly and effectively. It's been a huge barrier and a problem in a lot of rural communities in Iowa.
Dr. Fustino or Dr. Dickens, I don't know if you have much experience or with this topic, or, how can we get these, well, like Natalie was saying, the needles or the equipment that they need to treat kids to these outer areas that are away from Iowa City or Des Moines or larger metropolitan areas. Is there a solution there that is, I don't want to say easy, but
Yeah, I would say we have educators, nurse educators on our service when we identify a patient who's having an issue with their local ER to provide education. We give families, some of our families get our routine so they can present that as they go to the ED. But these are events that happen in the middle of the night, random times, and each one of these hospitals is staffed, their staffing and their equipment. That's not up to us to decide how they do that. That's their decision. So I think, as usual, Natalie said there's not many people like her, and I'm thankful that she is one of the people like her, because sometimes, like in advocacy, you need a community member to go to that hospital's administration and say, no, you got to understand this is important. And that has a much different effect than the University of Iowa telling a hospital in Dubuque that they need to purchase needles that they're going to use, maybe once a month for that child's treatment, and then not have another child for the next couple of years.
That certainly highlights a lot of the challenges, with a lot of rural communities we have here. Although I should certainly commend a number of them. When we do run into these situations where we need assistance, their communication is usually excellent, and they do their best to execute, the things that we need help with. I've had many situations in Iowa winters where the roads are not safe and you can only go locally. And I've even had to admit kids, more remotely, because I would step outside and slip in my own driveway while I was talking to a family. I was like, oh, this is not a good idea to try to drive an hour and a half, to Des Moines. But that's kind of the art also of what we do, and trying to figure out how to best help folks no matter where they live.
Okay. This is my last prepared question, but I think we also have at least one audience question. So if anyone who's watching has any questions for our panelists, just type those into the Q&A box, and our tech host, Elena, will get those to me. But many Iowans know about the state's cancer rates because of the Cancer in Iowa report that's published each year. And Dr. Dickens, I wondered, preparing for this panel discussion, I went to the Cancer in Iowa report and I thought I will pull the numbers for pediatric cancer, but they were not in there. So Dr. Dickens, can you tell us a little bit about that story? Like, where are the pediatric numbers? And then also, I don't know if I know that Dr. Fustino earlier shared that I think it was 140 kids in Iowa are diagnosed every year roughly, but any information you might have about, like, what is the picture of cancer in kids in Iowa?
Sure. So the Iowa Cancer Report that comes from the Iowa Cancer Registry, which is something that anybody can just Google and get the data, up until this point, has reported a statistic called age-adjusted cancers. So they're taking all the ages and they're mixing them all up, and that's the report that said Iowa has the second highest cancer incidence in the country. Kentucky is first, and one of only two states with a rising incidence. Utah is the other one. So that's the report people are familiar with. And up until now, they have not had a focused issue on children until next year. So next year's report is going to have at least a page, which is going to break out children and ask the question, how is Iowa doing relative to the rest of the country? Is this just an adult problem, or is it a kid problem? We just started looking at that data in preparation for next year's report. And I think the answer is sometimes it's the same problem and sometimes it's not. So in small children, 14 years of age and younger, the data is looking about like Iowa is at the national average. So if you're a little kid like Sage, we're doing about the same. And it looks like it's pretty much across the board. We haven't gotten to all the subtypes yet. but we're right about at the national average in children. In older adolescents and young adults, it looks like that's where the incidence rates is starting to rise, in particular with certain types of cancers, such as melanoma, which is a big one that's starting to stand out. Thyroid cancer is another one, and colon cancer. So I think when that data comes out, I encourage anybody who's interested to start using these references and look into what's going on in peds. We are going to have a problem with breaking this out by county. So the cancer registry breaks out hotspots across the state by county. And the reason why that's a challenge in pediatrics is anonymity. This is such a rare problem that if a county has a single child that's diagnosed with cancer, we're not allowed to report it because that would break anonymity. So, but some of the bigger counties will be able to have, Johnson, Lynn, Muscatine, Dubuque, some of the bigger more populous areas. So please look forward to that in 2026. Small kids, we're about national average. Younger adults, we have some pockets that we're definitely high in.
Yeah, this data is really hard to tease out in pediatrics, being such a rare phenomenon, and hard to pin down at the granular level for many reasons. What we have seen through kind of large national databases is that there has been a very slow increase in incidence of pediatric cancer over the last 50 years. And this is a real hard phenomenon to get a handle on as to what's causing this. Is there, increased gene frequency and predisposition? Are there environmental factors, lifestyle factors? And how to tease those out is a huge challenge going forward. So hopefully we'll have better data in the future.
Natalie, is this
Thanks,
significant?
Nick.
Oh, go ahead, Dr. Dickens.
I was just going to say that was an important separation. So yes, we are in small children, not different than the rest of the country. But what keeps us up at night is this slow creep where we are seeing a rising incidence over time. And it's not just technology getting better, because that's what I heard in the 20th century. But over the last decade or so, we haven't had huge gains in diagnostic tools. And that rate continues to rise just like the rest of the country.
Natalie, I was going to ask you, is this significant for you from an advocacy point of view or even a parental point of view, I guess?
Oh, to get that data broken down that way? Absolutely. Absolutely. Yes, there's been lots of times where I'm doing a presentation and I'm a data person. I like to see that, and you can't find it. So kudos to you, Dr. Dickens, because that's very, very good news.
Okay, we have a question from the audience, and this is someone who clearly knows something about cancer research, I believe. The question is, there are level 1 or 2 immunotherapy trials going on in Asia. It sounds like there is significant cure rate in people in stage 3 or 4 cancers. What are the results of the trial, or what are the results the trials are indicating?
I can take that one, Nick.
Okay, good.
Or let me start. I think I know what this person is talking about, and thank you for the question. So I mentioned this a little bit earlier, this immunotherapy and ways that you can manipulate the immune system to attack the cancer, your own immune system. Lots of different strategies and techniques to do it. For some types of cancers, and particularly some adult cancers, it's been a huge improvement. But it turns out these differences that we mentioned earlier about pediatric cancers and adult cancers, we have not seen the success. There's some success, but for example, leukemia, Nick was mentioning leukemia earlier. We used a form of immunotherapy for leukemia and completely changed the standard of care very recently to incorporate immune therapy to the point where some of those kids have a prognosis that's 95 to 100% with the immunotherapy embedded in. So that's one approach I could think of. But Hodgkin's disease is another one where we're manipulating the immune system But the differences in pediatric cancer biologically make them a little bit less prone to these kind of approaches being effective.
You mean like it's more difficult to manipulate their immune system?
Yeah, when you're doing with those kind of using those kind of drugs, it's helpful if the tumor itself has the immune system invading into it. And that doesn't happen as much in kids as it does in adults. So you can manipulate the immune system, but if it can't get into the tumor, it doesn't matter. So that may be some of the differences in the immunotherapy. I think the question also highlights one of the challenges we've had as pediatric oncologists is drug development tends to happen after a drug is developed for adults. So the adults would do a trial on a new drug, they figure out what works, doesn't work, and then there's then the experiments in children are done. Thanks to advocates like Natalie and Kids Free Cancer, Nancy Goodman, they have really worked on legislation to break down the loopholes that some of our industry partners were using to stagger drug development and put people out. That's a lot less possible today. And over the past 5 years, for the first time in University of Iowa's history, we've had pediatric-led phase one. That's the earliest phase of the studies that are opening specifically for children with some of our industry partners. We have 5 or 6 open now, and that was completely new since I got here in 2019.
Sorry, which part of that is brand new? The part that it's just for children, or
partnering with industry, having a pharmaceutical company start a clinical trial in peds rather than waiting till after they get results in adults.
Okay.
It just delays the success. So I'm not sure what drug is being referred to, but whatever drug is being referred to may be effective in peds. And if you wait until you do your adults first, it's going to take another 5 to 10 years before a kid is ever going to see it. So it's this, it was a legislative fix. It highlights the importance of advocacy. Somebody made it harder for drug companies to apply for a new FDA labeled indication unless they incorporated kids in their study. That was a legislative fix.
And previously it was they would do a study just for adults and then like use that same drug for children, or they wouldn't, or they would do the research after?
Yeah, historically they would be able to justify not researching kids because it's rare disease and it was slow up drug delivery, true. But those studies often get done until the children's oncology group picked it up. Once a drug is labeled, anybody can use it and prescribe it. So like Nick was saying, COG is a very organized structure, research structure to protect the safety of the individuals. So when you use a drug off label, that sounds really bad, but it's really thoughtful and is totally acceptable to do under the right circumstances. So historically, drug development happened after the drug was already labeled for something else. And then we did a trial in pediatrics, found it to be effective. And then it became a standard of care. But the drug company doesn't have to go back to the FDA and say, I want a new labeled indication because they already did that and it's too costly.
Huh. That's really fascinating. And we are about 2 minutes from the end, so I'm going to do my little wrap up comments here, but I could talk about, this is a really interesting conversation. But we are out of time, and I want to thank our panelists for taking the time to participate in this discussion. You bring valuable insight to this issue, and I hope you've inspired thoughts and conversations. Thank you also to our audience for their attention and participation. And thanks finally to ITC Midwest, which is the presenting sponsor of Iowa Ideas, and Unity Point Health Cedar Rapids, which is sponsoring In-Depth Week. This session has been recorded and will be available at iowaideas.com. There are 2 more days of Iowa Ideas discussions about cancer in Iowa this week. Tomorrow, the topic will be the economic impact of cancer on individuals and families. And then Friday, we'll wrap up the week with a discussion about advancements in screening and treatment. And both of those will begin at noon and last 1 hour. So thank you very much, Dr. Fustino, Dr. Dickens, and Natalie. I really appreciate you spending the hour with us. Thank you.
Thank you, Sara.
Thank you, everyone.
Thanks.
Thank you.